Hi everyone, we're back. We're going to be talking about attention deficit hyperactivity disorder, ADHD, which is found in the neurodevelopmental disorders section of your DSM right up in the front. We're going to be going over the DSM criteria for diagnosis along with the specifiers that are needed. And then we're going to talk a little bit about observable traits of clients that present with ADHD, what you will see. We're going to talk about ADHD in the brain. And then I have some data from a study on that the Center for Disease and Control and Prevention did in 2011. And then following this slideshow, I'm going to have you read the updated version of that study that can be found on a link right on Blackboard. And then we're going to take a little assessment. So let's start with the DSM-5 diagnostic criteria for ADHD. I'll give you a second to look that over. And please feel free, if you want to follow along in your DSM, you can jot down any notes. You can highlight anything that you need to highlight. The DSM should definitely be a working document. So I'll give you a couple seconds to look over the criteria. So when we talk about a client that presents with what looks like ADHD, there's a couple of things that we have to keep in mind. And if you look at Roman numeral 1 under the A on the slideshow, I've bolded a couple words, a couple key factors that come into play when diagnosing for ADHD. So for the inattentive type, 6 or more of the following symptoms have to have been there for at least 6 months. To the degree that is inconsistent with developmental level and that negatively impacts directly on social and academic activities. So what does that mean? That means that the client needs to have been having those symptoms for at least 6 months, and it has to be developmentally appropriate. So to diagnose a 2-year-old with ADHD who has difficulty sustaining attention and sitting still and paying close attention is not developmentally appropriate. So it's really important to take into consideration where your client is, where their age is, where their developmental level is. And then it has to negatively impact their social, academic, and occupational activities. Typically with kids, you're going to see this impacting them in the classroom. And with adults, it can impact them at work, and it can impact them socially as well. So if you look down the list from A through I, those list the symptoms that have to have persisted for at least 6 months. So most of them are about not being able to pay close attention to details, difficulty sustaining attention, not seeming to listen when spoken directly to. Kids will often have a really hard time following through on instructions. They'll fail to finish schoolwork, chores, or duties in the workplace. That's for adults. Difficulty organizing tasks. Sometimes clients will avoid tasks that require sustained mental effort because they know that it's hard for them to kind of concentrate and do that. Losing things, easily distracted by extraneous stimuli, and often forgetful in daily activities. If you look back at the top, there's a note there that is actually asking you to rule out other diagnoses when making the ADHD diagnoses. So you want to make sure that what is presenting itself is not oppositional behavior. It's not just defiance or hostility. And really important, it's not failure to understand task or instructions. Sometimes children that have learning disabilities can look like kids that have ADHD because they don't understand their tasks, they don't understand what they're doing, therefore they become inattentive as a coping mechanism. So it's really important to rule out those things. Here's the second part of the diagnostic criteria. This part deals with hyperactivity and impulsivity. Again, you need 6 or more of the following symptoms that have persisted for at least 6 months to take into consideration developmental level and that it's negatively impacting social, academic, and occupational activities. The note there provides you with the rule out again. We want to make sure that it's not behavioral, not defiance. It's not some sort of failure to understand tasks. Something else is going on. So this looks like clients that fidget with their hands, with their feet, where they leave their seats. So sometimes in the classroom, they can't sit still. They're bouncing all over the room. Runs about or climbs in situations where it's inappropriate. So I think of like at the grocery store, the kid that's climbing the shelf in the grocery store. Unable to play or engage in leisure activities quietly because their brain is always going and they're kind of jumping all over the place. Often on the go, talking excessively, blurts out answers before a question has been completed. You'll see that in the classroom. Has difficulty waiting his or her turn and interrupts or intrudes on others. So in terms of the diagnostic criteria, you also need to make sure that several inattentive or hyperactive impulse symptoms were present prior to the age of 12 years old. Several inattentive or hyperactive impulse systems are present in 2 or more settings. So if somebody is going to be diagnosed with ADHD, it's going to happen across settings. It's not just going to be you have ADHD in school, but you're fine at home, or vice versa. And there's clear evidence that the symptoms interfere with or reduce the quality of social, academic, and occupational functioning. So what does that look like? That might look like poor grades when there's no problems with intellect or ability, achievement, that kind of stuff. It might look like not being able to do your job if you're an adult, having trouble multitasking, having trouble putting things in order, and then that's affecting your job. And then the symptoms do not occur exclusively during the course of schizophrenia or another psychotic disorder and are not better explained by another mental disorder. So there's that rule out component again. So let's make sure that what we're looking at isn't anxiety. Let's make sure that what we're looking at isn't dissociative disorder, which was formerly multiple personality disorder. So really important to get a really good intake and a really good feel about what the client is experiencing in order to provide this diagnosis. So some specifiers that the DSM-5 talks about with ADHD are combined presentation. So this is both criteria 1, the inattentive type, and the hyperactivity impulsivity type are met for the past 6 months. So then that would be ADHD combined presentation. Predominantly inattentive presentation would be criterion A is met, but not criterion A2. Predominantly hyperactive impulse presentation, criteria A2 is met, but not criteria A1. In partial remission. So this talks about when the full criteria were previously met, and then there was a change. So fewer than the full criteria have been met for the past 6 months. However, the symptoms are still resulting in this impairment. So there's still something going on. You can specify if it's mild, if there's just a few symptoms and it's just affecting occupational or social or academic functioning in a mild way, moderate, or severe. And just a note too, and we're going to talk about this upcoming week in class, but those specifiers, they all have codes that go with them, and we're going to learn a little bit about how to fill out a progress note with the codes. But the specifiers are really helpful for a couple of reasons. They're helpful when you're communicating with other healthcare professionals about what's going on. And they're also helpful in terms of treatment planning. So if you have a client that presents that you've given them a diagnosis of ADHD and it's a severe type of ADHD and you're working on treatment goals and you look, 3-4 sessions down the road and you're talking about it and their symptoms have decreased to a moderate level, then you know that your treatment goals are working. So ADHD and inhibition. So just a little background. It's one of the most common neurodevelopment disorders of childhood. Children with ADHD, like we said, may have troubles paying attention, controlling impulsive behaviors, may act without thinking about what the result will be, or be overly active. So inhibition is a mental process that restrains an action, being a behavior or an emotion. So problems of inhibition are not a matter of choice, but are instead a result, it's supposed to say, of what is or what is not going on in the brain. So let's talk a little bit about the brain. So if you look at that picture, there's 2 pictures of the brain there. There's the control subject and the ADHD subject. And what's being highlighted is the frontal lobe of the brain. And this is important because it is where executive functioning is controlled. It's responsible for executive functioning. So executive functions are self-regulating skills. They're skills that we use every day to do things like plan ahead, stay organized, solve problems, and focus on what's important. Some other roles that executive functions play are consolidating information from other parts of the brain, considering potential consequences and implications of behavior, inhibiting or putting the brakes on impulsive reactions, and initiating appropriate responses to the environment. So, the research around ADHD suggests that children that have ADHD, in these children, these executive areas of the brain are underactive. So, what does that mean? In terms of treatment, that means that increasing the activity level in these areas of the brain has been shown to decrease behavioral symptoms. And this is the logic behind using stimulant medications as a first line of treatment for this disorder. We're going to talk a lot about medications, especially for each disorder, but for ADHD, in terms of treatment, because ADHD is biological, it starts in the brain. Medication is kind of the first line defense for ADHD, and then counseling, teaching coping strategies. But if you truly have ADHD, the medication is going to hit it like a hammer. It's definitely going to help. So here are some statistics. These are from researchers from the Centers for Disease Control and Prevention and the Health Resources and Services Administration published a study, Trends in the Parent Report of Healthcare Provider Diagnosed and Medicated ADHD in the United States, collecting data from 2003 to 2011. So these researchers conducted and analyzed the 2011 National Survey of Children's Health Data to estimate prevalence of parent-reported ADHD diagnoses. That's important, it's parent-reported. Current ADHD, current medication treatment, ADHD severity, and the mean age of diagnosis for U.S. children and adolescents from ages 4 to 17 years. And this is what the researchers found. They found that the prevalence, as of 2011, approximately 11% of children ages 4 to 17 have been diagnosed with ADHD. That's 6.4 million children in the United States. So I'm wondering, maybe you just want to take a second and jot down what your thoughts about that are, about that number. Do you feel like it's an overdiagnosis, an underdiagnosis? Do you feel like it's accurate? What are your thoughts about that? I'll give you a second to jot that down. So the researchers also found that the percentage of children with an ADHD diagnosis continues to increase. So in 2003, 7.8% were diagnosed. In 2007, 9.5% were diagnosed. And in 2011, 11.0% were diagnosed. So what do you think that means? What are the implications of that? Take a second to jot that down too. So if you look at gender differences between boys and girls, boys are more likely to have ever been diagnosed with ADHD than girls, almost twice as likely to have been diagnosed with ADHD than girls. So that has a lot of implications as well. The average age of ADHD diagnosis was 7 years of age, but children reported by their parents as having more severe ADHD were diagnosed at a younger age. And I thought this was interesting. The prevalence of ADHD diagnoses varied substantially by state, from a low of 5.6% in Nevada to a high of 18.7% in Kentucky. And next week, or this upcoming week, we're going to look at this study in more depth, and we're going to look at the maps of the United States and come up with maybe some hypotheses as to why this is occurring, why the prevalence is changing by state. The study also found, in terms of peer relationships, that parents of children with a history of ADHD report almost 3 times as many peer problems as those without a history of ADHD. And also, parents report that children with a history of ADHD are almost 10 times as likely to have difficulties that interfere with friendships. So take another moment to write for a second. Why do you think that is? Why do you think kids with ADHD are having so many peer problems according to the study? And why are they having so many difficulties with their friendships? And then the final part of the study I wanted to look at was the injury rate. I thought this was pretty interesting. A higher percentage of parents of children with ADHD disorder reported non-fatal injuries. So kids with ADHD are getting hurt more. Children with ADHD compared to children without ADHD were more likely to have major injuries, hospital inpatient, hospital outpatient, or emergency department admissions. And then data from international samples suggests that young people with high levels of attentional difficulties are at greater risk of involvement in a motor vehicle crash, drinking and driving, and traffic violations. So take another second to jot down why you think kids with ADHD. So this last slide, I just want to talk a bit for a second about this question, do I have ADHD? And ADHD is a hard one to diagnose. In terms of diagnosis, you're going to get information from the school, you're going to get information from the pediatrician, you're going to get information from the parents, and then you're going to have your own clinical impressions of what is in front of you. The thing with ADHD is that it looks like a lot of other diagnoses, especially in children who they don't have the ability yet to say, I feel this way, I feel anxious, I feel sad. Developmentally, they're not there. So other diagnoses that look like ADHD can include depression, anxiety, hearing problems, visual problems, seizure disorders, oppositional defiant disorder, autism, learning disabilities. We touched on that a couple minutes ago. Parenting issues, that's a big one. What kind of environment is this child growing up in? What's the relationship like between the parents? Substance use in adolescence can look a lot like ADHD. And here's something very important. So ADHD is biological. You are born with it. So you're not just going to acquire ADHD at the age of 13 or at the age of 35. You are born with it. So that's another thing to look at too. If all of a sudden all of these symptoms are popping up, it might not be ADHD. Medication side effects can look like inattention. Definitely lead poisoning in little kids can look like ADHD, and trauma most definitely looks like ADHD. So diagnosing it is it's really important. It's definitely a team event to diagnose ADHD because you're working with children and you're going to be talking with all the people that are involved in that child's life. So what I want you to do next is to take the assessment, the short assessment, and then make sure that you have written down the couple of items that I tasked you with from the study from the CDC. So have those for class next week. Thanks.